here, I have not broken proximal tooth contacts at all. Why? Because there is no need to. If there is caries, I would go ahead and open the contacts. If there is no caries, I am tempted to not open the contacts. And because I do not open contacts, think about it, there is no question of food lodgement after cementation. One major clinical problem addressed simply by altering your tooth preparation. More importantly, however, when you look at the basic outline of the preparation, all I have done is an occlusal prep. Why? Because nature had already taken away a lot of tooth structure from the occlusal. We are looking at doing reconstructive dentistry, which means there is no need to further reduce tooth structure. Simply go ahead and add what nature has already taken away. Conservation. That should be your motto when you look at doing these preparations, especially because remember, these are vital preparations. No need for endodontic treatment unless there is a bacterial problem, which means there is a pulpal pathosis, or you have exposed the pulp as a part of your tooth preparation, which should not ideally occur in these scenarios. Okay, now if you're looking at the concern with respect to bonding, yes, there is a lot of dentin present on this tooth. Look at the area that I have highlighted in yellow. All this is dentin. All right, but there is literature which says as long as you have peripheral enamel, that is 360-degree collar of enamel, your enamel will provide more than 90% of your bond strength, which means your dependence on the central core has significantly reduced. Remember, your lithium disilicate is crystalline in nature. Enamel is crystalline in nature. Both of these, when you etch, you apply a bonding agent and you use resin to fuse them together. These are two structures that are so strongly bonded to each other, they are not going to leave each other. It's like two best friends. Ye dosti ab hum nahi chhodenge. So as long as you have a beautiful ring of enamel, that's the white that's present around the yellow, do not worry. Go ahead and bond and sleep peacefully. Now you must be wondering, why have I given additional retentive grooves? You can see a groove on the buccal, you can see a groove on the palatal. Friends, this is not for retention. This is not for resistance. This is basically an orientation groove. When I do a flat tabletop preparation, I do not know where I am seating the prosthesis. And if I go wrong with the positioning of this prosthesis, my adjacent molar may not seat properly. So these grooves act like the orientation or the Google Maps, basically, if I may say so. And it allows me to position the prosthesis on its final location without any second thoughts. Okay, so that's the reason why I prepare these teeth in such a conservative manner, because it takes care of the biological principle, the mechanical principle, as well as the aesthetic principle. Okay, this is what the laboratory sends back to me. Tabletop on the posterior, partial bonded on the anterior. Laminate preparations is basically what I did for the mandibular anteriors, and again tabletop for the mandibular posteriors. Now, very important, because these are to be bonded, isolation is extremely crucial, which is why this should ideally be done under rubber dam isolation. You can see I have bonded the mandibular anteriors, followed by maxillary anteriors, followed by all the posteriors. And this is how it looks. Now, when you look at an occlusal picture, you will think to yourself, this looks like a full crown. But guess what? It's not, because look labially. These are mid-labial, all right? It is only and only restoring what nature has taken away from a functional perspective. It is restoring only what nature has taken away from an aesthetic perspective. The occlusion is beautiful because this is MIP now equal to CR. There is no hit and slide. There is no discrepancy between the condylar position and the maximum intercuspal position. This is something that's very, very, very stable. Now, I know there's a question lurking in your head. Is the patient okay with this? Guess what? The patient really is okay. Why? Because he is smiling as wide as he possibly can, and there is no portion of the underlying tooth structure that is visible. This is where I say You don't only satisfy aesthetic principles, but you conserve biology. You preserve the original tooth structure. Why? Because it allows you to come back and do a full coverage if worst case scenario something goes wrong. If you start with a full crown to begin with, you may not have a second option if something goes wrong. But here with partial bonded restorations, you have plan B, which means if something does not go as planned, you can resort to a full coverage restoration for that particular tooth if need be. All right, I know there's a question learning in your head again. How long do these last? Do they survive? Will they not break? Guess what? Because they are monolithic, they do not break easily. Because they are bonded to the underlying tooth structure, they do not debond or decement easily. All right. And the best part is, because you have Emax, which is say an enamel replacement material against an enamel replacement material, maxillary to mandibular Emax, the question of wear being caused because of your prosthetic material is also significantly taken away. 3-year recall that I have for this patient, look here, everything is extremely stable. As a matter of fact, the lower teeth that he had fractured, as you can see, we have now replaced with implant prosthesis. Now, the beautiful part about all of this is we did not weaken any tooth structure by doing unnecessary root canals, which means we allowed for the tooth to be strong. And at the same time, we saved a lot of money because root canals were not needed. All right. So although the total cost of the procedure does not change too much, remember at the end of the day, you have preserved a lot of your patient's tooth material. And I believe that is a massive service that we as clinicians can do for our patients. Yes, this is doable. Okay. Very quickly, let me show you a second case. And again, this is a case of a tobacco chewer. All right. Again, someone who you believe has no teeth in his mouth. Okay. And an extremely powerful physical human being. Okay. Look here. This is a terminally ill dentition, completely broken down dentition. I know a lot of dentists that I go around teaching who are my students. When I put this picture up and I ask them, what would be your prosthetic material of choice for restoring this case? I feel a lot of pain when they come back and tell me, I want to do monolithic zirconia for this patient. And I'm like, no. Monolithic zirconia should never be used for these kind of patients. Why? Because monolithic zirconia, yes, is too strong, but that strength is its biggest weakness in a patient like this. Why? Because your prosthesis is not going to break, but your abutment tooth may break.